Welcome to StudyNeuro. In this presentation, we will examine the pathology and pathophysiology of posterior communicating artery aneurysms, with emphasis on how these aneurysms form, enlarge, and eventually rupture. Important foundation topic. By the end of this session, you should understand the vascular anatomy involved in posterior communicating artery aneurysm formation and how structural weakness within the arterial wall contributes to aneurysm development. We will also discuss the role of abnormal blood flow dynamics next to the biological and mechanical factors that influence aneurysm growth and rupture risk. Finally, this presentation will connect the underlying pathology to common clinical features seen in patients, helping bridge basic cerebrovascular science with real neurosurgical practice. Join the StudyNeuro community across YouTube, Facebook, TikTok, Instagram, X, and X for more high-yield neuroscience education and clinical pearls. Posterior communicating artery aneurysms are among the most frequently encountered intracranial aneurysms in neurosurgical practice. They form at a key junction where the internal carotid artery meets the posterior communicating artery, a small but highly important vascular connection. Clinically, these aneurysms matter because they carry a high risk of rupture, often leading to subarachnoidhemorrhage. They also sit close to the oculomotor nerve, so nerve compression with eye movement problems is a common presentation. Understanding this relationship is essential for both diagnosis and surgical planning. Simple anatomy explains much of the clinical behavior. That point is critical. Overall, recognizing their location and nearby neural structures helps link pathology directly to symptoms and guides safe, effective management. Most intracranial aneurysms form at arterial bifurcations, where a parent vessel divides into branches. These regions are naturally weaker, and over time they become prone to dilation under constant blood flow stress. The weakness comes from a combination of structural and hemodynamic factors. Some vessels have congenital defects in the tunica media, while others develop degeneration of the elastic layer with age. On top of that, turbulent blood flow at branch points adds ongoing mechanical stress that gradually damages the vessel wall. As the aneurysm forms, its direction of expansion often follows predictable patterns. It commonly extends posterolaterally or inferiorly, and in the posterocommunicating artery region, it may grow toward the oculomotor nerve, which explains the clinical symptom pattern seen in many patients. It is a structural problem shaped by flow dynamics. That is the core idea. Aneurysm formation begins with ongoing stress on the arterial wall. Blood flow creates constant pressure, and over time, this repeated force gradually weakens the vessel structure. At the tissue level, the wall starts to fail in a stepwise way. Smooth muscle cells are lost, the tunica media becomes thin and fragile, and the elastic fibers break down, reducing the vessel's ability to recoil. These changes do not happen suddenly. They build slowly. The end result is a vessel that cannot withstand normal hemodynamic forces, making it prone to progressive dilation and aneurysm formation, especially at sites exposed to higher flow stress. Hemodynamic forces play a central role in aneurysm development. Blood does not always move in a smooth, uniform way, especially at arterial branching points, where flow becomes turbulent and creates localized stress on the vessel wall. This stress is more significant when anatomical variants are present. A larger, fetal-type posterior communicating artery can increase the amount of blood passing through the segment, which adds extra burden on the arterial wall over time. The vessel responds to this persistent mechanical strain by gradually weakening. The wall begins to bulge outward, and with continued exposure, this outpouching can evolve into a saccular aneurysm. It is flow-driven injury that slowly reshapes the vessel. That is the key mechanism. Aneurysm rupture is mainly a structural failure of a weakened vessel wall. As the aneurysm gradually enlarges, the wall becomes thinner and loses its normal ability to withstand pressure from circulating blood. This weakening is not uniform. Some regions become especially fragile, and over time, the structural support of the arterial wall is progressively lost, making it less stable under normal pulsatile flow. Certain features increase the likelihood of rupture. Larger aneurysms carry higher wall stress. Irregular shapes reflect unstable growth, and daughter sacs indicate focal points of weakness. A very thin aneurysm dome is particularly vulnerable because it has minimal structural support. Rupture is therefore not random. It is the final step of progressive mechanical failure. The oculomotor nerve travels through a tight vascular corridor in the interpeduncular region. It passes in close relation to both the posterior cerebral artery and the superior cerebellar artery, which explains why even small shifts in local anatomy can affect it. Its position is important. The nerve lies inferior and slightly lateral to the posterior communicating artery, placing it directly in the path of an expanding aneurysm in this region. When an aneurysm grows, it can press on the nerve and disturb its function. This is why patients may develop eye movement problems or double vision in these cases. This compression pattern is most commonly seen when the aneurysm projects posterolaterally or inferiorly. Those directions place the expanding sac directly toward the nerve. Mass effect from a posterior communicating artery aneurysm occurs when the expanding sac presses directly on the oculomotor nerve. This compression disrupts nerve function in a predictable sequence because the outer fibers are affected first. The superficial parasympathetic fibers are the most vulnerable. When they are compressed early, the pupil loses constriction control, leading to dilation. As pressure continues, motor fibers become involved. This produces eyelid drooping, double vision, and a characteristic downward and outward eye position due to unopposed muscle action. This pattern is clinically important. An acute third nerve palsy in this setting should raise concern for aneurysm expansion. Rupture of a posterior communicating artery aneurysm occurs when the weakened vessel wall gives way and blood escapes into the subarachnoid space. This is usually the final result of progressive wall degeneration combined with ongoing hemodynamic stress and rising pressure inside the aneurysm. Once rupture happens, blood spreads quickly through the basal cisterns. The distribution is rapid because these spaces are continuous, and this pattern leads to the classic picture of aneurysmal subarachnoid hemorrhage. The clinical presentation is often dramatic. Patients typically develop a sudden, severe headache, often described as the worst in life, along with neck stiffness, vomiting, light sensitivity, and reduced level of consciousness. It is a vascular emergency with a sudden onset pattern. That is the key clinical message. Hemorrhage from an aneurysm does not always remain confined to the subarachnoid space. In more severe cases, the rupture can extend into nearby brain tissue, the ventricular system, or even the subdural space. Once blood enters these compartments, it produces several secondary effects. A collection within brain tissue forms an intracerebral hematoma, while entry into the ventricles leads to intraventricular hemorrhage and disruption of cerebrospinal fluid flow. This can quickly progress to acute hydrocephalus, and in some cases, blood may also track into the subdural space. These changes raise intracranial pressure significantly. That pressure shift is the main driver of clinical deterioration. Patients may then show reduced consciousness, new focal neurological deficits, and signs of raised pressure such as papilledema. In severe situations, brainstem function can be affected, leading to respiratory compromise. When a posterior communicating artery aneurysm ruptures, the bleeding pattern depends on its anatomical location and nearby structures. The initial and most common event is subarachnoid hemorrhage, where blood spreads into the basal cisterns, especially the suprasellar cistern and the ambient cistern. In some cases, the rupture extends beyond the subarachnoid space. Blood may enter the brain tissue itself, often affecting the temporal lobe and the uncus because of their close proximity to the aneurysm. It can also track into the ventricular system. This typically involves the temporal horn of the lateral ventricle and may interfere with normal cerebrospinal fluid circulation. Less commonly, blood may extend into the subdural space, depending on the direction of rupture. The overall pattern is not random. It reflects the anatomical relationships of the aneurysm and surrounding cisterns and brain structures. Ischemic complications in aneurysm disease often begin with changes inside the aneurysm itself. In some cases, blood flow becomes unstable and leads to the formation of an intraluminal thrombus within the aneurysm sac. This disturbed flow environment promotes platelet aggregation and gradual clot formation. Once a clot develops, small fragments can break off and travel distally into the cerebral circulation. When these emboli lodge in downstream vessels, blood supply to brain tissue becomes reduced or blocked. The clinical outcome depends on the affected territory, but it may present as an ischemic stroke with weakness on one side of the body, visual disturbances, or transient neurological symptoms that come and go. It is a flow problem that becomes an embolic problem. That is the key mechanism. After a subarachnoidhemorrhage, blood breaks down in the cerebral spinal fluid and releases products that irritate nearby cerebral vessels. This triggers both vascular spasm and an inflammatory response within the arterial wall. The result is narrowing of the cerebral arteries. That narrowing can reduce blood flow enough to cause delayed cerebral ischemia, especially in vulnerable brain regions. When perfusion drops, neurological function begins to worsen over time. Patients may show a gradual decline in their exam rather than an immediate change, which is why continuous monitoring is important. It is a delayed vascular response with real ischemic consequences. Posterior communicating artery aneurysms develop from a combination of structural weakness in the vessel wall and ongoing hemodynamic stress. The junction between the internal carotid artery and the posterior communicating artery is especially prone to this process because of constant flow turbulence. The clinical picture depends on how the aneurysm behaves. Symptoms can result from pressure on nearby structures, from bleeding when rupture occurs, or from reduced blood flow in affected territories. One of the most important early warning signs is oculomotor nerve palsy, which often reflects local mass effect from the expanding aneurysm. When rupture happens, it can lead to subarachnoidhemorrhage, which is a life-threatening neurological emergency. Understanding these mechanisms helps connect anatomy with presentation and guides safer clinical decision-making. That connection is essential. Stay connected with StudyNeuro for more focused neuroscience learning and clinical insights. Like, comment, share, and subscribe for more updates. Thanks for watching.